Ischemic reperfusion injury by Ahmadaglin, MD, Alexandria University Critical Care Department.
In the name of Allah, the entirely merciful, the especially merciful. Welcome. In this lecture, we will unravel the complex and critical paradox of ischemia reperfusion injury, the phenomenon where the very process of restoring blood flow to a starved tissue inadvertently causes additional, often catastrophic, damage. We will begin with a clear definition and explore its significant impact on clinicum, setting the stage for why this is a central problem in fields from cardiology to critical care. We will then dive deep into the intricate pathogenesis, breaking down the destructive cascades that are unleashed. This includes the pivotal role of calcium overload, the explosive burst of reactive oxygen species, the damaging effects of reactive nitrogen species, RNS, the consequences of hydrogen ion overload, the activation of the complement system, the dysregulation of the renin-angiotensin system, RAS, and the resulting capillary failure. We will examine the resulting pathology at the cellular level, detailing the stark choices cells face through autophagy, apoptosis, and necrosis, and the central problem of endothelial dysfunction. Finally, and most importantly, we will address the crucial questions: how can we avoid IRI? And once it's underway, how can we? Let's begin by defining our challenge. Let's start with a precise definition. Ischemic reperfusion injury, or I/or injury, is the cellular damage that occurs after blood flow is restored to previously viable tissues that have been exposed to a period of ischemia. Let's break down the critical elements of that statement. First, the tissue was previously viable. This means the cells were alive but struggling during the ischemic period. The injury isn't from the ischemia alone, it's the act of reintroducing oxygen and blood that triggers the destructive cascade. Second, this is cellular damage. This isn't just a theoretical concept, it manifests as measurable harm to the cell's structure and function. And finally, a key clinical principle: injury increases with delay in reperfusion. The longer a tissue is deprived of blood flow, the more severe the reperfusion injury will be. This damage ultimately forces the cell down one of two fatal pathways: programmed, controlled death of apoptosis, or the uncontrolled, inflammatory cell death of necrosis. In essence, I/or injury is a double-edged sword. Reperfusion is necessary for survival, but it also activates the mechanisms that lead to the tissue's final destruction. The most effective strategy to avoid ischemic reperfusion injury is, fundamentally, to avoid prolonged ischemia itself. The core principle is simple: reducing the time of hypoperfusion is paramount to preserving organ function. This creates a critical, therapeutic window for reperfusion across numerous medical disciplines. Time is tissue. Let's look at key examples. First, in a stroke, we have a narrow window for thrombolysis or thrombectomy to reperfuse the ischemic brain penumbra, the tissue at risk. Second, in coronary thrombosis, the mantra, "time is muscle," drives emergency angioplasty to a blocked artery and save the myocardium. Third and fourth, in damage control surgery and orthopedics, the strategy is to rapidly control hemorrhage and contamination, then temporarily close the patient. The goal is to terminate the initial insult and restore perfusion before proceeding with definitive repair, thus minimizing the time for vital organs and limbs. Fifth, in sepsis, early goal-directed therapy aims to aggressively resuscitate the patient, correcting hypoperfusion before cellular damage becomes irreversible. And sixth, in cardiopulmonary cerebral resuscitation, CPCR, the entire objective is to restore spontaneous and oxygenated blood flow to the brain and other organs as quickly as possible. In every case, the clock is ticking. The success of our interventions is inextricably linked to how swiftly we can re-establish blood flow. When ischemic reperfusion injury occurs, it forces the affected cells down a path of destruction. The specific type of cell death that ensues has major implications for the surrounding tissue and the overall inflammatory response. Prolonged IRI can lead to several distinct, yet sometimes overlapping, modes of cellular death. First, apoptosis. This is programmed, controlled cell death. It's a cleaner, more orderly process that typically doesn't provoke a significant inflammatory response, but it still results in irreversible cell loss. Second, autophagy. This is a complex process where the cell attempts to reheal its own damaged components in a last-ditch effort to survive. In the context of severe IRI, this survival mechanism can become overwhelmed and can itself contribute to cell death. Third, necrosis. This is unplanned, catastrophic cell death. The cell swells and ruptures, spilling contents into the environment. This directly triggers a powerful and damaging inflammatory response. And fourth, necroptosis. This is a specific, regulated form of inflammatory cell death that shares features with both apoptosis and necrosis. It is a major contributor to the tissue damage in IRI. It's also critical to understand that the injury doesn't stop the moment blood flow is restored. The reperfusion stage is a dynamic process that can persist for several days, with waves of inflammation and cell death continuing to expand the area of damage long after the initial ischemic insult is over. Before we can understand the injury of reperfusion, we must first define the initial insult, ischemia. Ischemia is formally defined as the hypoperfusion of tissues, resulting in two critical failures: subcritical oxygen delivery, the blood flow is too low to deliver adequate oxygen to the cells. Subcritical oxygen extraction, the tissue's ability to extract and utilize what little oxygen is delivered becomes impaired. This dual failure creates a profound energy crisis at the cellular level. The causes of this hypoperfusion are diverse but share this common endpoint. Major causes include sepsis, where systemic vasoconstriction and microthrombi disrupt perfusion. Acute coronary syndrome, where a blocked artery directly cuts off blood supply to the heart muscle. Organ transplantation, where the donor organ inevitably suffers a period of ischemia between retrieval and implantation. Limb injury, from traumatic vascular damage or syndrome. And any form of shock, whether hemorrhagic, cardiogenic, or distributive, which all ultimately lead to global tissue hypoperfusion. In every case, ischemia sets the stage. It creates a vulnerable, energy-depleted tissue environment that is primed for the explosive damage that can occur when blood is finally restored. Thank you.